apply an overall view. What is multiple sclerosis? Autoimmune. That's a good point to make. Autoimmune. Progressive. Right? Irreversible. Or I wouldn't say irreversible, it's probably one. No cure. Is a better way to phrase it. And what this does is your immune system is attacking your nerves, more specifically the myelin sheath. Now if you don't know what the myelin sheath is, imagine this is your nerve inside, and you have this covering on the outside like a wire, right? You guys know that the wire is not made out of plastic. It's either like copper or metal, some sort of conductive material inside, some type of metal. But the outside we cover it with plastic, because the plastic will not shock you, right? It protects the wiring so nothing disturbs it. And it allows electricity to flow very nicely, and that covering is keeping everything inside intact. That's why when the plastic breaks, what happens? Right, it doesn't work, or maybe you have to position it a certain, because you're trying to make the inside now reconnect because it's getting disturbed. Same thing with your nerves. So what this is gonna do is it starts taking out little pieces of your myelin sheath, of your wiring. And so then this allows for the nerve, right, function to come apart. The signals can be disrupted, and now it's no longer flowing in a nice, even manner all the way across. Make sense? You're destroying the fatty tissue around. Okay? So, immune-mediated attack or infection destroys the myelin sheath. As a result, demyelation interrupts the conduction of nerve impulses. Plaques can then form on the demyelinated axons, leaving them unable to regenerate and cause irreversible damage. MS can affect the nerve cells in the CNS, central nervous system, which is your optic nerve, brainstem, cerebellum, and spinal cord. This can result in worsening function of voluntary muscles. So, risk factors. Look at how we can prevent it. Risk factors. Age 20 to 50 years is the onset. Sex assigned at birth. Females are at higher risk. 2 to 3 times more likely to get it. Genetic predisposition, so if you have a relative, genetics, viruses or viral illnesses, living in the cold, injury, emotional stress, pregnancy, I'm not sure how that sets the onset, maybe because of the stress of it. Temperature extremes is more significant. So things like taking hot showers. Nothing good comes of your hot shower, by the way. Huh? Nothing good comes of your hot shower, other than you can exfoliate a little better because your pores open up. But other than that, your skin is dry as hell. You're irritated as hell. You come out looking like a tomato. All burnt, all irritated. But it feels good. So does cocaine, but we're not.
I don't
I believe that's how, when you ever visit there, they're like, these batteries, like, but it feels good. And it's like, oh, okay, let's do it.
Food tastes good.
It does not taste good. But let's pretend to say like cake. Cake is good, but it's bad for you. You don't have to take a cold shower. I'm not telling you to like go in like freezing. But maybe at best, warm, tepid. Huh? Do you think the water heater will make Do you guys hear this guy?
No,
You need to stay warm.
That's why you take the cold one.
You said you're cold when you come out.
Yeah. It's a
This is what happens in America when you live in a cocoon and you're unable to feel cold for the 2 minutes you spend drying yourself. Throw on a shirt.
Aren't you American?
Yeah, but I don't complain about cold water. I grew up poor, dude. I didn't have water here for days. Regular, just straight up. And in El Salvador, you shower with a bucket. Cold water. You're not dry, you're wet again. It's hot over there, but that's how you feel the cold more. Alright, expected findings. Pay attention to the expected findings, if this was the issue. Okay, fatigue. Hey, I'll try to highlight some that are more like, kind of like, remember, like fatigue can be for like anything will make you feel fatigued. Okay? But for example, like meningitis, they're like, oh man, you're gonna feel like crap, like malaise or fatigue. Yes, it's an infection. But what's more specific to meningitis? The stiff neck. The fact that it's an infection will lead to a fever. Okay? So for this one, a big one is coordination. What's that? That's why, yeah, like your coordination will be altered, is what you say. So in coordination, you'll notice ataxia. Intentional tremors. I would just say tremors. You'll see memory loss and impaired judgment. Okay. Sensory, you'll notice paresthesia, vertigo, visual disturbances, diplopia, peripheral, let's say changes in peripheral vision. Peripheral vision. Decreased visual acuity, how well you can see. Blindness, or say periods of total blindness. Nystagmus. Dysphagia. Dysphagia, also known as difficulty chewing or swallowing, problems eating. Wowzers. So term one, it's like the first thing you learn in term one, like the first medical term. Let me see. Monitor for dysphagia. I love Miss Joyce. She's such a thug with her Cortezes. She like seriously walks around here just like all G'd up in Cortezes. Dysarthria. Also spasticity. Also weakness. Bowel bladder dysfunction. See, and this is why you have select all that applies, because I'm not about to ask 10 questions on this. You can know a good 5 of them, that's pretty good. A lot of them do have partial credit, because now that's how it is. For sure, the next gens, if I put next gens on there, they're built with partial credit. Okay. So some of the more relevant ones is you should know this general. This is kind of like generalized of poor coordination and memory loss. Their cognition, obviously, is again affecting the brainstem, cerebellum. Okay. I would say a very good way to summarize the vision ones. Just think of visual changes or disturbances. That's how I would do it. Whether it's diplopia, nystagmus, decreased vision, partial blindness. You could just put a good term for you to just remember is visual disturbances, visual dysfunction. Make sense? And if you see something that is like a word of those that is affecting the vision, you should be familiar. Dysphagia, dysarthria. So trouble like speaking with them, they have slurred speech, trouble chewing, swallowing. Okay, and then bowel, bladder, and sex dysfunction. All kind of fall in the same thing. You can just think of genitals, right? The genital dysfunction, whether it's for bladder use or for sexual use. This all relies on a lot of our function and retain relies on nerve function. So multiple sclerosis, as you can see by what you're assessing, a lot of it comes down to this demyelination, this disruption of the wiring around your nerves, all leads to decreased motor function. Things that we use every day, hence the spasming, tremoring, right? They can't function, they can't hold their pee, poop. So all of this, their intentional motor function is gonna be decreased, because as you're trying to send the signal to move your arm, it's gonna be disrupted. Okay? Now, it does have periods of like exacerbation and remission, and things like fatigue. So maybe we can quickly go back to risk factors or what's happening here. These exacerbations can be triggered by like fatigue, stress, more than anything, stress and infection make these exacerbations, meaning like these flare-ups, during which the attacks are worse, and you try to treat it and suppress your immune system, and it'll go away. It's less actively eating at you. But during these periods of infection, stress, where there's a lot of activity and your immune system is more active, you're gonna eat away at your nerves a lot faster. Yes? Okay? Just like with Parkinson's, you'll die from complications of it. It's not so much like that it finally ate enough of your brain, you just die, but you'll aspirate, your immune system can be too suppressed, and you'll just die from infection. It's from the decreased amount of function. You're laying down in bed, and as you know what's gonna happen, they're gonna develop pressure injuries, infection, and the list just goes on and on. You're gonna die from a complication of a decreased motor function. Just like people don't necessarily die from HIV and AIDS, but you still attribute it to it, but what realistically killed them? An infection. An infection or the cancer developing from the decreased immune system. But at that point, with your white blood cell count so low, you're not like, well, it's the flu. And they did, but it's also attributable to the fact that they have HIV or AIDS and their white blood cells too low. Make sense? All right, moving on. Lab test. So you'll assess their cerebrospinal fluid. Cerebrospinal fluid. You'll see elevated protein. Mild increase in WBCs. In the electrophoresis, you don't need to know doctor or questioning on it. You see white blood cells, T lymphocytes, immunoglobulins, and just immune response. To diagnose, we will see an MRI, and this MRI will show those plaques of the brain and spine, those plaque formations. This is the most diagnostic. Optic nerve transmissions will be altered. But the big thing is the plaques that you see forming on the brain and spine. And when it demyelinates, eventually, what's missing there, just these plaques take over. Okay, now more importantly, what do we do? So, it says monitor the following. These are part of the expected findings: visual acuity, speech patterns, swallowing, their activity. Obviously, we're monitoring for those things. Encourage fluid intake and other measures to decrease the risk of urinary retention. Right? Okay, so increase fluids, help them be able to urinate properly. These can include intermittent catheterization. What do you guys know what that is? Straight catheters, in and outs. Okay. Craig's maneuver, so manually expelling the urine. Spell like this, Craig's maneuver. Where you push on the bladder. They'll say establish a time, so what you should have is like a voiding schedule. Kind of like bladder training, so you go every hour and a half or every 2 hours, for example. Then every 3 hours and every 4 hours, and hopefully they can hold it every 4 hours. This helps train the bladder. Okay. Monitor their cognition. Reorient the client helps. Have a routine. place items in the same place or like in a routine place. Does they have dysarthria, trouble communicating? A good way is a communication board or like a picture board or here it says like help them communicate. Now common things to help people that have trouble speaking communicate or aphasia is write a communication board with like pictures. They can write it out. The one pictures helps because they can just point whether it's food, water, right? They need to go urinate, they need to go have a bowel movement, right? Like they can tell you they have pain, they need to be adjusted. It helps them easily make their needs known. Exercise and stretch. Group their care to provide too much exertion. Okay. Fall precautions. Use a walker, right? And then they can use an eye patch for the diplopia, which is double vision, right? So if you close one eye, it makes it easier to see, to avoid the double vision. Now, if you look at their meds, there's a few that I want you to focus on, and it's the disease-modifying therapies, for example, the things like the interferon, the glitarimer, terflunomide. The big thing with these is and then you have another one, which is your prednisone, again, where it says other medications. You have prednisone, dexamethasone, corticosteroids. The meds for this are likely to focus on what? Decreasing inflammation, decreasing your immune system. Because remember, in autoimmune diseases, what's attacking you is your own immune system. So if we bring down your immune system, it's less likely to attack you. But then this leaves you open to infection. So what will you report? Fever, sore throat are the first two and the most common signs of the infection that you should report. With prednisone, you should be familiar with your prednisone. Corticosteroid. We know that they can go into Cushing's disease, but more importantly, right, it causes hyperglycemia. Okay. With long-term use, what can develop? Osteoporosis. We already talked about the risk for infection even in the short term. And then how do you ever stop this medication? Taper off. Meaning you slowly decrease the dose to let the body adjust. So what kind of people will we need for this? Like what kind of interprofessional care? PT, OT, speech, pathology, maybe. But those are the three focused ones. You want to maintain their mobility, their speech, swallowing ability, their ADLs. I left one thing out. With the eye patch and the diplopia, their visual disturbances, especially if they cover one eye, what's something they should learn to do? Do a vision scan. Yes. Side to side. So if, let's say, you patch up the left eye, you want to teach them to consistently do this. Okay, so that they can then also see the left side. So when you serve the tray, tell them to make sure that they turn the whole way so that they can see all of the food that they have. And this comes also for people with stroke or just visual loss, that they have lost like sight in one eye, whether that's from neurodeficits or they're just blind from one eye. You want to teach them to vision scan. Always scan their environment. Always turn fully so that they're aware of their entire environment. It's a safety thing. Alrighty. We good?